Hey everyone, it's Nurse Mike here from SimpleNursing.com. Today we're covering asthma, talking about all the signs and symptoms, treatments, and diagnostics like the peak flow rate. Now, this one is big on the NCLEX. So, for all my Simple Nursing members, be sure to grab your asthma study guides inside the membership. And now, let's take a deep breath and break it down. Asthma is a chronic inflammatory disorder in the major pathways of the lungs, the bronchi and the bronchioles. When these guys get inflamed, it's called bronchoconstriction, since the bronchi constrict down and get tight. Unlike COPD, which is irreversible, resulting from long-term chronic damage, mainly to the alveoli and bronchi, like from years of smoking or other inhaled toxins. Asthma is very different in that it comes and goes with flare-ups in the form of asthma attacks. Now, these are reversible. Another key difference is that only the bronchi are involved here and not the alveoli, and it typically does not cause long-term damage. So think of the double A's. A for asthma, A for acute attacks that can come and go, typically triggered by anything that can irritate those sensitive bronchi, like cigarette smoke, pollen, dust, strenuous activity, and even cold weather. But we'll talk about the triggers later in a moment. Whatever the cause, during the asthma attack, two key things happen. First, the bronchi puff up with inflammation and get very tight. Again, this is called bronchoconstriction. And secondly, the body secretes excessive mucus from the goblet cells that line the respiratory tract, resulting in wet, mucus-filled lungs. Now, this is super deadly since the respiratory tract gets so constricted, closing off any and all oxygen to the alveoli. This means no oxygen in, so we get decreased inhalation, and no CO2, that carbon dioxide, out, resulting in air trapping, making it hard to exhale. Now, this leads to acidosis in the body, which could lead to deadly respiratory failure. Be sure to have this study guide handy for this section, so you can follow the content and make this knowledge actually stick. Now, in terms of the signs and symptoms, we use the acronym ASTHMA. And a little tip here, focus on the highlighted ones below since these were the most tested out of 5 different exam question banks. So A is for accessory muscle use, due to the increased work of trying to breathe. And a key critical sign here is paradoxical breathing. Write that one down. It's very deadly. This indicates diaphragm muscle fatigue. And a little NCLEX tip here. Focus on the most deadly signs since these are the most tested signs. S is for shortness of breath and dyspnea, that difficulty breathing. And a critical sign here is single word dyspnea. T is for tight chest and tachypnea, that fast respiratory rate. So just think about it here. Air trapping in those inflamed lungs lead to tachypnea, a rapid respiratory rate. You're unable to take a full deep breath. H is for high-pitched wheezing, probably the most classic sign of an asthma attack. It sounds like a whistle, due to that inflammation causing narrowed airways, sounding a lot like this. M is for minimal diminished breath sounds. Now, this next part you need to write down. The key signs for deadly respiratory failure and deadly status asthmaticus, just think of the 3 A's here. So our first A is for absent breath sounds. This is known as a silent chest. Now, this is priority. Write this down. On exams and the boards, if your patient suddenly stops wheezing during an asthma attack, this is not a good sign. The NCLEX will not suddenly cure your patient for you, so exams won't give you a cured patient. This typically means that the lungs are puffed up so much and get so tight that it completely cuts off all oxygen and airflow, leading to the last 2 A's here. Acidosis, that CO2 retention, and air trapping. So we get prolonged exhalation. Write that down. Prolonged exhalation. Now, don't get tricked here. Not prolonged inhalation. We see the key term once again, prolonged exhalation, breathing out. So just think of the patho here. We have inflamed lungs, right? So we can't get oxygen in. We have short inhalation, not prolonged. And you can't get CO2, that carbon dioxide, out. So the key term, prolonged or longer exhalation, that air exiting the body. So in result, CO2 builds up in the body, causing acidosis from that carbon diacid, that carbon dioxide. Now for a big patho test tip for your pathophysiology on acid-base imbalances during acute asthma attacks. So please be sure to write this down. Many exam questions love to ask about the early stages and late stages of acute asthma attacks. So for early stages, we see respiratory alkalosis from hyperventilation. The client is breathing off too much CO2, that carbon dioxide, right? So the memory trick, just think of panting like a dog from hyperventilation. Breathing out all that CO2 or that carbon dioxide, the client will be in alkalosis. So they're going to be breathing off that CO2, which pushes them into an alkalotic state. Now for late signs, after the client is exhausted from too much breathing or hyperventilation, they're going to progress into respiratory acidosis. So eventually, as the client tires out, the respirations become slower and slower, leading to this respiratory acidosis from the CO2 retention. So hypoventilation from retaining too much CO2. So the memory trick, just think of someone snoring with low and slow breathing. It kind of sounds like respiratory acidosis as someone snores. So again, just think low and slow breathing, we retain a lot of CO2, that carbon dioxide. Looking for more tips and strategies for questions like the ones we just covered? Well, our Simple Nursing membership includes exit prep lectures and thousands of questions across all nursing school and NCLEX topics. Now for the critical complications. If this carbon dioxide gets too high, it can lead to hypercapnic respiratory failure. We're just talking high CO2. The key term here is respiratory failure from that high carbon dioxide. Basically, we have an acid crisis. So let the name help you here. Just think hypercapnic as high carbon dioxide, resulting in high acid that pushes the body into that acidotic state from carbon dioxide. So once again, the memory trick, just think carbon diacid for carbon dioxide. It makes the body an acidotic state. Now, this results in acid crisis, which shuts down the lungs. So the key numbers to know for ABGs, those arterial blood gases, is number 1, a pH less than 7.35. This indicates acidosis. A PaCO2 over 45 is acidosis, and a PaO2 less than 80 is hypoxic. Now, the first sign of hypoxia is that mental status change. Now, this goes for any condition. So the ones to know, there are 3 of them. First is agitation. Second is restlessness, and then drowsiness. So once again, if you're talking neuro, respiratory, any condition on the NCLEX, you have to know these 3 signs as the earliest sign of hypoxia. Lastly, as mentioned before, status asthmaticus is a medical emergency. It's an asthma attack that will not resolve with medication. Basically, the patient gets stuck in this asthma attack. We're talking inflammation so severe that no airflow is possible, and the client dies. So the priority intervention in any critical complication is number 1, an endotracheal tube or endotracheal intubation. So write that down. Again, typically the most deadly key points are the most tested key points. Now for another patho side note. A key sign of status asthmaticus is pulsus paradoxus. Big test tip here, so be sure to write this down. We see a drop in systolic blood pressure more than 10 millimeters of mercury. Now this is a huge indicator of the asthmatic emergency, status asthmaticus. Pulsus paradoxus is when the blood pressure decreases by that 10 millimeters of mercury during inhalation and then increases during exhalation. You see, asthma increases that negative pressure within the lungs, and this puts a lot of added pressure on the heart, particularly the left ventricle, which is the part of the heart responsible for pumping out all the oxygen-rich blood to the body. So this pressure on the heart causes pulsus paradoxus. Now, the three items that pulsus paradoxus includes is number one, a decrease in stroke volume. And stroke volume, again, is how much blood comes out of the ventricles with each pump, which makes sense since the heart is being squeezed here, so naturally we're going to see a decrease in stroke volume. And number two, we see a decrease in systolic blood pressure, which is the number on top of a blood pressure number. Now, I call this the systolic squeeze, as it measures the amount of force being pushed out of the heart into the blood vessels after each heart pump. So naturally, with the heart that's being squeezed down here, we get a less forceful pump with less pressure coming out of the heart. So basically, less systolic pressure, that systolic squeeze. And finally, number three is pulse wave amplitude during inspiration. As you know, during normal breathing, there is a fall in pressure less than 10 millimeters of mercury. Now, this is natural and to be expected. But once again, when the drop is more than 10, then this is referred to as pulsus paradoxus. So be sure to write that number down, a drop in systolic blood pressure more than 10. Now, switching gears to diagnostics, we can use a pulmonary function test, also called a PFT, but this was not really tested on directly, so I would not focus on this. Now, teaching, I would focus on the peak expiratory flow rate. Now, this is used to take a peek at the client's peak airflow, sort of like a weather forecast. We want to anticipate a severe asthma attack before it happens. So the device we use is called a peak flow meter. This device measures peak airflow to see how tight the airway is before symptoms get worse. So it kind of works like a traffic light. We have three zones: green, yellow, and red. For the green zone, just think green means go. Asthma is around 80 to 100% under control. There should be no worsening symptoms, so no further medication is needed. Now, the next one, write this down, is the yellow zone. Yellow, think mellow. Asthma is not under control here. There's a huge need for additional medication. So once again, the memory trick. If the score is yellow, we need to mellow out that asthma with additional medication. So write down these key points. Number one, a rescue drug is used every 4 hours for 1 to 2 days. And number two, we have to call the HCP provider because we need additional medications or a change in the treatment. Now write that down. The NCLEX will try and trick you here. Patients must follow up with their primary provider even if they return to the green zone after taking the rescue meds. Now, most students get this wrong on various question banks. Remember, yellow is a warning sign here. We need to mellow out that asthma with additional meds. Lastly, we have the red zone. Now, red, just think really bad. Emergency treatment is needed immediately if the level does not return to yellow right after taking those rescue drugs. Now, switching gears to the correct order of how to use a peak flow meter. Number one, we stand or sit in upright position. Number two, put the flow meter scale to 0 or the lowest value. Number three, you inhale deeply and then put the mouthpiece in the mouth and create a seal with the lips. Now, number five, write this down. Exhale as quickly and forcibly as possible and record the reading. Then number six, repeat 2 more times with a break of 5 to 10 seconds in between. And then lastly, write this one down. Record one score, which is the highest score of the 3 attempts. Now write down the highlighted key points here. Many students get these 2 wrong on various question banks. And don't let the NCLEX trick you here. We take 3 attempts. We do not average the 3 attempts. So the key point is that we do it 3 times, but we only record 1 score of the day, which is the highest score. And lastly, don't let the NCLEX trick you again. A personal best score is obtained over a 2-week period when asthma is controlled, and not from a daily reading or a daily best score. Okay, now as far as teaching triggers, just think of the A's and the S's for asthma. A for allergens like dander, dust, and pollen, as well as elevated eosinophils, which is a blood test that indicates an asthma attack was triggered by an allergic reaction. So write that down. This one came up a few times on various question banks. Now don't get tricked. It was eosinophils, which indicates allergies, not neutrophils and not lymphocytes, which indicates blood cancer and infection. So the memory trick, just think eosinophils as ew, nasty allergies. Having a lot of gross mucus just dripping everywhere, like eosinophils. Okay, next is the S's. So S is for smoking, even secondhand cigarette smoke, and S for stress, from emotional or even physical. Now Kaplan states, further teaching is needed when which statement is made. And the correct answer, stress does not cause my asthma attacks. Yes, this needs further teaching since we know that stress does actually cause asthma attacks. And the last three S's here. S for sickness, like influenza or even a URI, that upper respiratory tract infection. S for severe weather, especially in the cold. And the last one's a little bit tricky here. S for strenuous activity. There's no need to avoid exercise. So just take the meds before exercise, and this is a tricky one again. Many students get this wrong, so listen up. Patients do not need to avoid physical activity altogether. We simply instruct the patient to take meds 20 to 30 minutes before the exercise to prevent that exercise-induced attack. And secondly, don't get tricked here. Latex does not trigger an asthma attack, and neither does antibiotics like cephalosporins or even penicillin. These guys cause other allergic reactions, but not an asthma attack specifically. Many students chose this on a few different question banks and got this wrong. All right, hold your horses. Here's another patho side note. You should know the two different terms that revolve around asthma flare-ups. We have extrinsic and intrinsic factors here. So starting with extrinsic, just think external. This occurs in response to allergens that are outside of the body. Basically external for extrinsic. For example, pollen, dust mites, and even mold, like we mentioned before. It is classified as a type 1 immune reaction, or a type 1 hypersensitivity reaction, with an immediate allergic reaction, where an allergen enters the lungs and the antigen combines with an IgE antibody on the surface of pulmonary mast cells that line the lung tissue or pulmonary epithelium, to be all fancy. Now the key point here is, remember, mast cells are responsible for massive inflammation in response to allergies, contributing to chronic airway inflammation response when overactivated. Now switching gears to intrinsic or internal factors here. This asthma is typically triggered by something inside the body and not by allergens outside the body. So some refer to this as non-allergic asthma. So please be sure to write this down. Asthma hyperresponsiveness, which is typically adult onset. These asthma attacks are brought on by the four S's. So S for sickness, like a respiratory infection. Once again, just think intrinsic. This infection is inside the body. And S for stress inside the body. The third S is for severe weather, like cold. Okay, now this one is technically outside the body, but you kind of get the idea here. It's not technically an allergen. Now, the fourth S is for strenuous activity and that exercise, which once again is brought on by self. And lastly, another outside factor are drugs. There are certain over-the-counter and prescribed drugs that are known to trigger asthma. So let's cover those right now. Now, speaking of drugs, the two to know that can cause an asthma flare-up. So N for NSAIDs, just think N for not good for asthma. And to help you remember all the names for NSAIDs, we made the nifty acronym NSEC. Now, from this list, just focus on naproxen and ketorolac. These are typically used most often on the NCLEX and exit exams, so recommend pausing your screen and writing these down. Next, we have B for beta blockers, which puts the brakes on the heart, ending in LOL, like propranolol. Just think B for it blocks the heart rate and the lungs. Beta blockers block beta 1, so just think one heart is blocked, and it can also block beta 2, so think 2 lungs are blocked, but only if it's non-selective, like propranolol, brand name Endurol. This is non-selective, so basically meaning that both the lungs and the heart are blocked. Now on the other side, atenolol is selective. It's called cardio beta 1 selective, so it selects only the heart to block and does not block the lungs or impact the respiratory rate. Make sure to pull out this study guide for this section so you can follow the key points. Now in terms of pharmacology, we have an entire series in our respiratory pharmacology master course, but we'll do a quick recap here. Now we have 2 teams, the bronchodilator BAM team and the anti-inflammatory SLAM team. Now I recommend focusing on the bronchodilators and the S in SLAM for steroids. These are typically the most tested. So starting with bronchodilators, B is for beta 2 agonist, and the drug to know is albuterol. So just think we give buterols for brutal asthma attacks. And it's considered the one and only rescue drug for asthma attacks. We always give buterols first before any and all drugs during an asthma attack. So that's why we put it here first on the list. Now A is for anticholinergics, and ipratropium is the drug to know. Now this dries out the body, decreasing secretions and dilating the airways. So just think the dry here. You can't pee with a tropium. And M is for methylxanthines, ending in phylin like theophylline. So just think it's very toxic and a very fast heart rate. And the therapeutic range to know is 10 to 20. So the memory trick we use, think phylins have you phylin toxic and tachycardic. So Kaplan mentions aminophylline or aminophylline is a bronchodilator. And Hesse mentions the therapeutic range for theophylline is 10 to 20. Now on the other side, think of the SLAM team for anti-inflammatory agents. We have S for steroids ending in zone like beclomethasone. And the top side effects to know, just think of the 3 S's for zone ending steroids. We have S for sores in the mouth. This is known as oral thrush. So instruct the clients to wash their mouth out after every use. And think steroid inhalers go right into the sink at least twice per week. The next S is for sepsis and sickness, since steroids increase the risk for infection, increasing the WBC count inside the body. And the last S is for sugars that are increased. Now, these are completely normal, so we have to watch out for these. Now, the last 2, which are not highly tested here, so I wouldn't focus on them too much. We have L for leukotriene inhibitors, ending in Lucas, like Montelukast. Now, the brand name is singular, so just think Luke likes to sing. And M is for mast cell stabilizers, like cromolyn. But again, it's not highly tested, so I wouldn't focus on these too much. Now, switching gears to meter dose inhaler teaching. ATI mentions a client should hold their breath for 10 seconds after inhaling so that the medication can get into the deep airways. And Kaplan mentions a need for further teaching when a client states, I will be careful not to shake the canister before using it. No, we need to shake the canister, so further teaching is needed here. Thanks for watching. Did you know you can unlock beautifully handcrafted study guides, packed with key points and memory tricks from all our videos? Plus, you'll get access to over 1,200 exclusive videos not on YouTube, all neatly organized by nursing school topic, to make that complex nursing knowledge actually stick. You'll also gain thousands of practice questions written by current professors and actual NCLEX writers. So for access to all this and more, click right up here or visit simplenursing.com. And don't forget to subscribe to our YouTube channel. Happy studying, and we'll see you in the next videos.